Good morning, everyone. Thank you all for coming today. I hope you weren't too intimidated by the talk title of the literature review, 1960 to 2021, but I really had a lot of fun putting this talk together, and I think there's just a lot to be learned about this. And so my objectives for you all today is to understand the progress we've made in the study of AKI and dialysis, and then solidify realistic expectations regarding the use of dialysis and AKI. And the things I want you to think about are the benefits, harms, and certainly limitations, and use the results of recent clinical trials to inform patient care. So, I was asked to give this talk, Literature Review AKI, for Aspen. And I knew in the back of my mind that it's really supposed to be the last year, but I thought I would just start broadly. So at least you'll be able to see that I did narrow my talk a little bit. And so I looked up PubMed, and there were over 68,000 studies that came up. And then, kind of just acute kidney injury in the title was 13,000 results. Strangely, when I looked up acute kidney injury by journal, there wasn't much in the major journals. Maybe I did that wrong. And so I went to NEFJC, I went to Google, and then I ignored COVID because I think we're all pretty fatigued with COVID right now. And so as I thought about what I wanted to try to focus on, I came to this slide, which I think some of you have seen me show in some of the talks that I've given. But I really like thinking about historical context and thinking about where we are and where we're going in our field of AKI. And so you can really think about, these are what I have described as the major eras of AKI in our history. First, acute renal failure is bad. We've known that since pretty much the history of time. That's why this starts here. We went through an interesting phase where in 1945 was the first successful performance of dialysis, and that was in somebody with acute renal failure. And so we knew it was possible. And then in 1972, Medicare for All passed for ESRD patients. And we really got this feeling that dialysis was just so good for our patient, which it was. But at the same time, there was this thought that acute renal failure really wasn't bad. And there are very few studies about acute renal failure and its harms during this time. But then this landmark study came out in 1996, and we realized more and more that acute renal failure was bad, and we changed the name to acute kidney injury. We still know that acute kidney injury is bad for you. And we went through these other eras with dialysis, from dialysis as possible to maybe if we do more dialysis and increase the dose, that might be better. And then later on, we were sort of thinking that earlier dialysis must be better. And these are some of the landmark trials, and I won't go through each one now because we're going to go through them all in the talk. So this is just another way to sort of present these eras. There's two acute renal failure eras, that is bad eras. The more dialysis is better, and these are the studies, and then the timing studies. And so when I'm sort of thinking about this particular talk about sort of the literature review and what's happened in the last year, the question is there really anything new? I found these two studies, new related to AKI and dialysis. And I found these two studies that I'm going to talk about, but I'm going to put them in context. This first study on my left is about dose and dialysis and mechanical ventilation. And the second study I think you're all familiar with is the AKI 2 trial, which is about timing. And so we're going to go through all of these eras, and I promise that it will be worth it, and I hope will be interesting, and I hope will help you think about how to take care of your patients with AKI that require dialysis. And so 1996 was really the new beginning of the AKI as bad era. And for context, really the dogma of that time was that acute renal failure was bad because people with acute renal failure were already sick. And it was the comorbidities that were killing people. And the phrase at the time was that people die with acute renal failure, not of acute renal failure. And even that it was an acceptable and treatable consequence of intervention. So that if you gave your patient, for example, amphotericin B and they got AKI, so what? That's not going to be harmful. We can just do dialysis and maybe fix it. So in this study, there were over 16,000 patients who got contrast, and they compared a subset of studies who got acute renal failure to 194 matched patients that did not develop acute renal failure. And their primary endpoint was mortality. And what they found was that the patients that did not have acute renal failure had 7% mortality, but those with acute renal failure had 34% mortality, with an adjusted odds ratio of death of 5.5. And they found an increased occurrence of all these other complications: sepsis, GI bleeding, delirium, and respiratory failure. And we know that our patients with AKI have increased rates of sepsis and respiratory failures. Many studies have confirmed that finding, and those are the things that are killing our patients. But this was the first study to really kind of say the high mortality rate in acute renal failure is not explained by underlying conditions, and that it appears to increase the risk of developing non-renal complications that lead to death and should not be regarded as a treatable complication of serious illness. And so this is just a smattering of some of the studies. They're all very early because this is when I first started thinking about it. But there are dozens and dozens of studies showing that AKI is an independent predictor of mortality, pretty much in every setting. Gives you an independent increased risk of mortality and increased adjusted odds ratio of death. And I want to highlight this study. This was a multinational, multi-center look at mortality of AKI in pediatric patients in the ICU. And they have an increased adjusted odds ratio of death. And they did statistical gymnastics to control for everything possible. And they still have an increase in mortality. And it's important to consider that these are kids. So they're not like patients with COPD and diabetes and some of these other comorbidities that we thought might contribute to mortality. So we've checked off this. Error number 2, AKI is bad and continues to be associated with increased mortality. So now we're going to go into the second era, which is that maybe the way to fix this is with dialysis, and maybe the way to fix the complications are with higher dose dialysis. And so what I'm showing you is the three landmark studies that you should know about, and then the KDIGO recommendations that came about from that. And so this study came out in 2000, and we were really thinking that more dialysis must be better. And this study showed that more dialysis was better. The study was a single center, 2 ICUs. I wonder if it really was 1944, I bet not, to 1999, randomized controlled trial of patients planned for renal replacement therapy. And their primary endpoint was a 20% reduction in mortality in the groups. And so this is interesting. So they looked at 20 ml per kg per hour versus 35 ml per kg per hour versus 45. And they had 3 different groups, and they had statistically significant reduction in mortality with higher dose dialysis at 35 ml per kg per hour and 45 ml per kg per hour. And I remember quoting this study when I was a fellow and rounding with Charles, and he would point to the dialysis bag and look at this, we're getting rid of all this stuff, we're getting rid of cytokines and other good things. And it was really the thinking at the time that if we had higher dose dialysis, we'd be removing harmful substances and be improved mortality of our patients. And so their interpretation at this time, published in 2000, was mortality among these critically ill patients was high, but increased rate of ultrafiltration improved survival significantly. And they made a recommendation that ultrafiltration rates should be prescribed and reach at least 35 ml per kg per hour. So then the ATN trial was published, and that really convincingly showed that more dialysis was not better. And this was a multi-center ICU study, AKI plus one organ failure or sepsis. And the primary endpoint was what we care about, 60-day mortality. And their endpoint was a reduction of 55% to 45%. And they compared 20 mil per kg per hour or thrice weekly intermittent hemodialysis with 35 mil per kg per hour. And it's pretty clear with high numbers of patients, over 500 in each group, the mortality is similar. No statistically significant difference in mortality, 52 versus 54%. But there were more complications with higher dose dialysis. So no benefit, but hypotension requiring vasopressors was higher. Hypotension requiring another intervention was higher. Hypophosphatemia and hypokalemia also occurred at a greater rate with higher dose dialysis. So no benefit, but definitely harms. And then the Renal study came out, and that definitively showed as well that more dialysis was not better. And again, this is a multi-center ICU, AKI, and needs renal replacement therapy. And I want to highlight this part right here, that all these studies didn't, of timing and dose, especially the timing ones, if there was an indication, you started. So hyperkalemia, acidosis, you started. So their endpoint was 90-day mortality, and they looked at a 8.5% absolute risk reduction as their primary endpoint. And again, the low dose, 20 mil per kg per hour versus 40 mil per kg per hour. And this is over 700 patients per group, and a shocking sort of exact rate of mortality, around 45%. And again, they showed that there was hypophosphatemia was greater in the augmented group. And none of these other endpoints were changed. And so in 2012, the KDIGO guidelines came out, and these are still sort of the most up-to-date KDIGO guidelines regarding acute kidney injury. And so in section 5, dialysis interventions for treatment of AKI, they took into account these studies and the dose of renal replacement therapy in AKI. And you can see this recommendation right here. Basically, the first one is, decide a dose, monitor your dose, which we're able to do at University of Colorado pretty easily. Get rid of the electrolytes and acid-base problems and fluid that will meet the patient's needs, because that's what dialysis does. And then this recommendation, we recommend delivering a KT over V of 3.9 per week when using intermittent dialysis. This was level 1A recommendations. It's really interesting. There was a commentary on this, that KT over V is more complicated than just adding them up. And what this really was meant to be was a dose of 1.3 per session, 3 times a week. And this was highlighted by Polevsky and all on their commentary on the KDIGO guidelines. So this is our recommended dose of intermittent dialysis. And then the CRT dose is this effluent volume of 20 to 25 mil per kg. And that came from those studies. So we've proven really that higher dose dialysis isn't better. So I think this is really interesting. This secondary analysis came out this past year looking at the intensity of renal replacement therapy, and was a secondary analysis of the ATN trial. And I have the pictures of these balls here, just showing how the pendulum can really swing in different directions. And that's kind of where we are now, because we hypothesized that compared with less intensive renal replacement therapy, intensive renal replacement therapy would lead to longer duration of mechanical ventilation, i.e. intense dose would be harmful and you'll be on the ventilator longer. And of course, since that was their hypothesis, that's what they found. And so they did find that longer duration of mechanical ventilation occurred with more intense renal replacement therapy. There was a greater likelihood of reintubation, longer duration of mechanical ventilation with continuous versus intermittent. And their explanation was phosphorus. And that's going to come up a lot. You saw that that was a common harm. So I think this study, this figure is very convincing. The red line at the top is high dose dialysis, and the blue line is less intensive dialysis. And this is extubation from mechanical ventilation, showing a clear separation of the group, that the more intensive patients were on mechanical ventilation. So this is their explanation. This is the phosphorus data. Red, again, is the higher dose, and blue is the regular dose. And these are median and interquartile ranges, and then the minimum and maximum values. And if you kind of follow this along, you know, it's a pretty wide variation, and not, in my mind, a major separation between phosphorus levels. And in fact, the mean nadir of serum phosphate was lower in the more intensive group compared with the less intensive group. We're looking at 2.6 versus 3.1. You know, if I were an early investigator, I don't know if phosphorus and mechanical ventilation would be what I would choose to look at. There are reasons to think it could be true. We know that hypophosphatemia does impair respiration related to diaphragm function and ATP, but these differences just don't seem impressive to me. So the question I'm wondering is, what is low phosphorus a surrogate for? You know, what else are we removing that can help us breathe? And we're going to see a lot of these phosphorus replacement studies down the pipe, and perhaps they'll show an improvement in mechanical ventilation time, but I suspect they'll just be able to replace phosphorus. And so going back to these KDIGO guidelines, I think it's important to revisit this last guideline. This is the recommendations, still the recommendations of delivering an effluent volume of 20 to 25 ml per kg. But I really think that the most fair interpretation of all these data is that we give a dose no more than 20 to 25 ml per kg per hour. We certainly know that this is the ceiling. I'm not confident we know what the floor is. I'm not suggesting that we try to figure out what the floor is, but this is the recommendation based on the current guidelines. So we've talked about dose, and now we're going to talk about timing. And so these are the 4 studies that I think are important to consider regarding the timing of dialysis. So this study was published in AJKD, last author, Jamali, in 2013. It's a single center with community-acquired AKI, and they did early start versus usual start, BUN of 70 or creatinine of 7 for the early start. And the primary endpoints were in-hospital mortality and renal replacement dependence. And so they had 100 patients in each group. And it'll be clear in a minute why I'm showing you this study. Mortality was actually worse in early start, but not statistically significantly worse, and no change in RRT dependence. So why is this study important? So I was asked to do an editorial on this, and I thought it was really interesting. So here's our nice study of Jamali et al. With 208 patients. And in 2013, at that time, the number of patients that had been enrolled in clinical trials of early start renal replacement therapy, randomized controlled trials, was only 196. There had been 5 before that, and the total number that had ever been enrolled in a trial was under 200. So this is a landmark trial because it had so many patients compared to the past, and showed that a timing study was possible. People really worried about equipoise and, you know, should we really be investigating timing? And so the important part to think about with all of our studies of dialysis and outcomes is, was this a realistically powered study? Do we have enough patients in our study? And so this is what's really important to keep in mind with all these AKI trials that you read about. So the numbers you need, so I did the math. So the number that you need for some definitive trials in the ICU with AKI, high-risk non-ICU with AKI and non-ICU patients with AKI. If you want mortality as your endpoint and a realistic improvement in mortality, if you're doing in this study in the ICU, you need over 1,000 patients. And this is any intervention, not just dialysis. If you're in the high risk of mortality, non-ICU, about 3,000 patients, non-ICU patients with AKI, you're going to need over 6,000 patients. And these are sort of, just to remind you, this is with a 15% relative reduction in mortality, and these are with 20% relative reduction in mortality. And these are similar to the ATN and RENALT studies that had 18% relative risk reduction in mortality and 14 relative risk reduction in mortality for as their power calculations. So, burn this slide into your brain of the number needed to be enrolled to really get good answers. And so this is why, Elaine was published, I think, in either JAMA, New England Journal. And, I don't like to criticize clinical trials because I know they're really hard, but I think it's time, with a study of 231 patients showing improvement in mortality, we have learned our lesson by this time in 2016 that this is an underpowered study and is not answering a question. And so let's talk about these other 3 studies that were well powered. So AKI 1, the conclusion is that early dialysis was not better. It's multi-center ICU, sick people either on mechanical ventilation or receiving catecholamines without an urgent indication. Remember, if they had hyperkalemia or acidosis or fluid overload, they got dialysis. And so early start was without randomization. Delayed start was urgent or a BUN greater than 112 or oliguria. And a reasonable mortality outcome, although it's kind of generous. It's more than what you'd really expect. And so here the 301 group, 300 in the other group, mortality is exactly the same. These patients are clearly different. So the BUN at start is 52, creatinine is around 3. And in the delayed group, it's higher, 90 and for the BUN and 5.3. And these timings, the timing is really hard because the timing is based on different definitions. So I think it's important to just keep track of the BUNs and creatinines, but they really could wait a long time. This is 57 hours that they could wait after being randomized. So again, so no difference in the primary endpoint of mortality, but really interesting results. 49% of patients in the delayed group did not get dialysis. And there was earlier diuresis in the delayed group. And again, a higher rate of complications in the early group. So 10% versus 5% rate of catheter-related bloodstream infections, higher rate of hypophosphatemia. These other outcomes were pretty much the same. So this study is telling us that early renal replacement therapy is worse, and you might be dialyzing a lot of patients who might otherwise not have gotten it. So then Ideal ICU came out, and again, this showed that earlier dialysis was not better. And this was a multi-center ICU study of pretty sick folks with septic shock without an urgent indication. And their primary endpoint, again, was mortality. And this is a pretty realistic change, kind of like what ATN did. 55 versus 45 was their power calculation. And so again, over 200 patients in each group. You can't blame them because the study was stopped early for futility. Same mortality. And again, similar levels of BUN and creatinine in the early versus delayed strategy. And so again, as I mentioned, the study was stopped for futility, so you can't blame them for not having higher numbers, but it's a good number. 38% in this study did not receive dialysis in the delayed group. And again, there's complications. So higher number of days on renal replacement therapy in the early group, One thing to kind of keep in mind is that there were a number of people who met criteria for emergency start related to hyperkalemia, fluid overload, et cetera. But these other endpoints, fluid balance, all these things that we think could be good weren't changed. So the net, it really is that early renal replacement therapy is worse. And now we get to the START AKI study, which again showed that early dialysis is not better. And this is, I think the ATN trial is one of our best trials in AKI, and the START AKI trial just makes me proud to be someone who studies AKI and to just know that this study exists in our field. And so this was a multi-center ICU, AKI stage 2 or 3, again, without urgent indication. And I love that they incorporated nephrologist approval to enter the study. So it's almost as if they had a group that was what the nephrologist thought, our clinical judgment. And early start was just protocolized. Standard was the nephrologist thought it was okay to wait, and we're going to start when the nephrologist thinks it makes sense to start. Primary endpoint was mortality, again, a realistic treatment effect. And there's no difference in mortality. And this is just, again, I give it a star because it's what makes me happy to see this, nearly 1,500 patients in each group. Like, this is a convincing study. There is no difference in mortality with early start dialysis. And again, really good separation of the groups. The BUN in the 60s, creatinines in the 3s, and then here in the standard start, 85 versus 4.9. So again, a large number of patients did not get dialysis, 38%. And there's quite a few harms associated with early start. So greater dependence on renal replacement therapy in the accelerated group, adverse events, again, higher in the accelerated group, 23% versus 16.5%, hypotension, hypophosphatemia, mechanical ventilation free days, other outcomes were the same. So we kind of have this feeling, well, if we get them started early, these other kind of outcomes would be better, but they're not. And so we're done talking about this era for the moment. Earlier dialysis is not proving to be better. And so again, the pendulum swinging. This is delayed dialysis versus even more delayed dialysis. And this is the AKI 2 trial that just came out. And so basically they showed, again, that later dialysis was not better. And so this is a multi-center ICU trial, AKI with oliguria more than 72 hours or a BUN greater than 112. That was the randomization criteria. And so this was delayed start when they met these criteria, which was the usual start, I suppose, in those other studies. And then they compared that to even more delayed start with an urgent indication, or if you could wait it out to get a BUN of 140. And the primary endpoint, and this is critical to understand this study, is renal replacement therapy free days. Taking into account that all those studies seem to show that dialysis begets dialysis, that earlier start meant you were on dialysis more. And so there was no difference in their primary endpoint, 12 versus 10 in the delayed versus more delayed, and only 100 and some versus 100 and some in each group. So this is, not a big trial. And so it's hard to make major conclusions, I think, about it. And it's a well-selected population of people who could actually go without a complication to a BUN of 140. It turns out the average was 123 in the more delayed group. And there's definitely a separation between the groups. And so I'm going to show you, it's really interesting, 21% in the more delayed group didn't receive RRT. So it's interesting. Even if you wait forever, there will be people who didn't need it. So one thing that they highlight in the study, and I want you to be aware of in case somebody quotes it back to you, is that 60-day mortality was lower in the delayed group and higher in the more delayed group. This was their p-value, but then when they did this multivariable analysis to identify risk factors, it came up as a risk factor with a hazard ratio of 1.65. But remember, the point I've been trying to emphasize, that mortality studies in AKI with any intervention in the ICU requires around 1,000 patients. And if we look at ideal ICU and we believe those studies, maybe you can get away with 300 patients in each group, but 100 and some versus 100 and some in each group, we can't take this mortality endpoint as being conclusive evidence that delayed renal replacement therapy is associated with increased mortality. That wasn't their endpoint. I don't think that they can say that. And part of the reason I feel kind of confident about this is when you look at the different, so if you look at this box here, mortality at day 28, at day 60 at ICU discharge and at hospital discharge, there's no difference in mortality at 28 days. This is the p-value here, 0.26. At ICU discharge, 0.26. At hospital discharge, 0.5. And the 60-day one just comes out of nowhere. So I really think if they'd had 2 more patients die in the delayed group and had continued to enroll patients, that this effect would have gone away, because none of the other endpoints, except for the patients who received, the number of patients who received renal replacement therapy and time to renal replacement therapy, there was no other endpoint that was significantly different. And so I would just keep this in your pocket, and because I don't want people to take away from this study that, oh, well, we don't want to wait too long, and that gets us back to, oh, we should start early. And so again, to sort of bang home this point of early RRT and the summary of harm. So I calculated some number needed to harm with these studies with the AKI one and START. It was easy because they had the percentages. This, I would have had to work harder. I could do that probably later. But for number needed to harm in a AKI one for the catheter-related bloodstream infection was only 20. The development of hypophosphatemia is 14. And in START, the composite number needed to harm, composite adverse events was 15. If this was a therapy that was good for you, we would be excited by a number needed to treat of 15. And you only need 15 patients to harm with early dialysis. And this doesn't count the number of patients that you are likely putting on dialysis that don't need dialysis if you start folks earlier. So in a AKI 1, almost half the patients in the delayed group didn't receive RRT. In ideal ICU, they broke it down. So 38% in the delayed start group didn't get RRT. 29%, so a third of that whole group that was in the delayed group, didn't receive RRT because of spontaneous renal recovery. And again, in START AKI, 38% in the standard group did not receive renal replacement therapy. So just to summarize these timing trials, again, these are the creatinine and BUN aren't horrible surrogates of what early versus standard initiation times are. Creatinine's around 3 and BUNs in the 50s and 60s is early. Creatinine's around 4 to 5. 80 to 90 is standard, and then delayed is this. So early RRT strategies are associated with harm, associated with excess initiation of renal replacement therapy, and perhaps maybe even at least a third of patients will receive RRT who would have recovered kidney function spontaneously with these early studies. Our standard approach is kind of the Goldilocks. It balances resource utilization and outcomes and is appropriate treatment strategy for the majority of patients. And this really delayed renal replacement therapy probably just isn't a viable treatment approach for the majority of our patients. So we're done with ERA 2. We've got a little bit to go. We're going to go through ERA 1 and arrow 1 over here next, and a couple more points thinking about dialysis and how we apply this to our patients. And so I was made aware of this study by something that Paul Pilevsky had written. And this was a kind of a thing that was done in JASN to highlight some of the landmark studies in nephrology in general. And I think it's just really kind of cool. And so this was a study published in 1960, and I encourage you all to take a look at it. You can find it in JASN, actually, but this is reprinted from the Annals of Internal Medicine. And this was the very first study of early dialysis in the treatment of acute renal failure. And this is this table 1 is their background. And they're like, acute renal failure is bad for you and has a high rate of mortality. And so this is 1953, 54, 56, 57, 57, 59. And these are their mortality rates, really kind of 40 to 70%, with usually around the 50%. And then there's this one group where it wasn't quite so bad. And so like they're sort of the way we are today. This is bad. Dialysis is good. If we get in earlier, maybe we can help our patients. That was their hypothesis. And so this was their first 15 patients with this approach, and kind of the description of what they had causing their AKI. And so only 5 of these 15 patients died, so their mortality rate was around 30%. So they were pretty excited about that. And they said, you know, I think we should not wait until the BUN is above 120, unless there's something bad going on. And so you can think of this as either a depressing slide or a putting everything into context slide. You know, our mortality rates of AKI on dialysis in 2021 are pretty similar to the mortality rates in the 1950s. But looking at, you know, 40 to 50%, 40 to 50%. But we have now convincing evidence with high numbers of patients on what dialysis is capable of doing and when it's appropriate to initiate dialysis. So my last point, you know, these are our phases. You know, AKI is still bad. We know that more dialysis is worse. We know that early dialysis is worse. So let's just talk about dialysis for a second. And there seems to be, in my mind, I think, magical thinking about what dialysis can and can't do, sometimes in our field, and certainly outside of our field. And it's our duty to kind of really integrate all these studies and integrate our history and communicate to our colleagues what can and can't be accomplished with dialysis. It's kind of interesting. I had to give a talk to the pulmonary critical care docs, and I needed to do an introduction on dialysis. And if you look on Google Images, this is always the image of dialysis, is some, you know, really happy patient, you know, thoughtfully looking at their dialysis circuit, and, you know, blood gets cleaned, blood comes back. It's really nice. We've gone through all these namings, but it's dialysis. You know, and then, okay, you know, this is somebody in the hospital getting dialysis, and, you know, you get it 4 times a week and it's good. But really, you know, the reality is our patients are really sick. And so when you look at images of continuous renal replacement therapy, I think this conveys a different picture of kind of what we're up against. And my favorite one, I hope you've been able to see my pointer, is this middle one right here, continuous renal replacement therapy. And they tried to make it look organized. They lined up all the machines here so it just kind of looked less chaotic. But the reality is that these are sick patients and they have a high mortality rate. And so then I found this ad, and I don't know anything about Solvay. I just don't know, but I think this this explains so much of the problem to me. So they're advertising their dialysis filter. And their title is Making Membranes as Efficient as Kidneys. And so, you know, they've got the blood going through and then the dialysis fluid. And I added these arrows, right? And all the bad stuff goes out. And in our hemodialysis filters, our dialysis filters, CRRT, have a cut point of around 60 kilodaltons. So all these things, you know, the blood stays here, all the toxins, small proteins, all this bad stuff is removed. But this isn't making membranes as efficient as kidneys. It's making membranes efficient as a sieve. And so this is what renal replacement is constant sieving of the blood, but it's not as elegant as what the kidney does. And ultrafiltrate and urine are not remotely similar. And I love this quote, you know, there are no normal plasma values because there are no normal urine values. And so the dialysis circuit is not appropriately modifying the ultrafiltrate the way the kidney appropriately modifies urine. And so in summary, there is no way to do dialysis that will improve mortality. And over a half century of clinical experience and clinical trials support this statement. We can fix potassium, we can fix acidosis, and we can lower the BUN, and that's what we can expect from dialysis. There are ways to do dialysis that will harm our patients, and we have over a half century of clinical experience and clinical trials to support this statement. Too much, too high of a dose leads to hypophosphatemia and prolonged mechanical ventilation. Too early, i.e. protocolized when a nephrologist probably wouldn't start, but perhaps some of our surgery and internal medicine colleagues might want to start. And the harms are going to be renal replacement therapy that is not needed, increased infections, hypophosphatemia, increased rate of RRT dependence, and hypotension. Too late, you know, BUN greater than 120, greater than 140. This has kind of been our thinking for quite some time. And there are ways to do dialysis that will consume excess resources. So again, dialysis that is not needed. And then, you know, excess testing for electrolytes and electrolyte replacement, excess medications and treatments for hypotension, just like more work. And nephrologists know what they're doing. We've got a study proving that. And improving mortality in patients with AKI will require therapies and approaches beyond dialysis. And I'm happy to hear your questions and thoughts.
Thank you, Sarah. That was great. There's one question from Melanie. It's in the chat box. It states, who are the 1/3 of patients predicted to have recovered on their own without renal replacement therapy? Predictors, biomarkers.
We don't have that. And I am skeptical. We have it a little bit. Actually, I'll take that back. So those kinds of things weren't looked at in this study. But I think that probably the best predictor, one of the best predictors we have is the furosemide stress test. Jay Coyner, Mink Chawla, if you look up those names, and that's where you give a dose, and we do this all the time, give a dose of furosemide, and if they have urine output, I think it's over 200 cc's in the next 2 hours, they are likely to recover and not need dialysis. And so that's probably one of the most useful biomarkers predictors. There are some of the AKI biomarkers have been studied for that purpose, although they weren't developed for that purpose. And I think that the results are kind of mixed. There's some thoughts that maybe NGAL in patients with hepatorenal syndrome might be useful, but those results are murky and are going to take us some time to develop. But I would say if there were one that's useful and clinically used and well studied, would be the furosemide stress test.
Thanks. Sarah, one comment regarding the phosphate section. It's interesting, and I agree with you that a 0.5 milligram per deciliter gap or difference doesn't appear to be clinically significant. But when you extrapolate that to the chronic kind of diseases of kidney disease, chronic kidney disease, dialysis, it was interesting. 0.5 milligrams per deciliter change up as an upward trend was also associated with mortality and cardiovascular events. So from an epidemiological point of view, changes of 0.5 in phosphate, for whatever reason, going towards hyperphosphatemia or hypophosphatemia, appear always to be related with events. But to your point, it has never been appeared to be clinically relevant.
Yeah, I think that the association is real, and it's nice to know that with the ESRD population as well. It's just whether fixing FOS alone is going to improve the outcomes we care about. My strong suspicion is that it's a surrogate for deficiencies of other things. So I'm very interested to see what these clinical studies of AKI with FOS replacement, because I think Baxter is trying to put it in the bag. Some of these companies are trying to put it in the bags, and whether that will improve other clinically relevant outcomes just with FOS replacement, I'm really interested to see.
Yeah, no, I agree with you.
I'd just be curious to see how those people were being fed in the ICU. So enteral feeding versus non-enteral feeding was probably a big association with whether their phosphorus was high. And we know enteral feeding in the ICU improves overall survival. So, that's kind of interesting.
Sarah Stu here. You made a comment and brushed by it that the intensity studies are 20 on the high end, 20 to 25 versus higher doses, that perhaps 20 to 25 may actually be more than is needed, or we tend to do daily dialysis even when the potassium, acid base, et cetera, are controlled on the acutes. Could you comment on that end of things? So, do you think that less dialysis actually is going to be best?
I really do. Yeah. What do you think? I think we all kind of, especially when you think about like the intermittent patients, right? Like they get done Monday, Wednesday, Friday. We could do CRRT that way, but we don't. And I think that CRRT controls things a lot faster, maybe than it used to. I don't know, but it feels like we get rapid uremic control with CRRT. After like a day and a half, the BUN is fine and we're having to replace phosphorus. So I think that what I would say about less dialysis is that I don't think that continuous renal replacement therapy needs to be continuous. That's my sense.
I would come the same way. We can buff the numbers pretty quickly, and you made the comment before that what we buff is the potassium, volume, blah blah, and we're not really doing other things. We don't know what we're doing, and so in my mind, I'm not sure it's phosphorus. I'm not sure what it is. I don't know that the daily intermittent stuff or the 24/7 continuous stuff is necessarily what we need to do or is in the patient's best interest.
Yeah. Yeah. And I think, again, I would encourage everyone to read those older studies, because I think, those patients were being dialyzed at a BUN in 20, where you could see improvement in front of your eyes. That was when, like, going from 200 to 100 is where you get your benefit in terms of uremic toxin removal. And these people who were like lethargic and lying on the floor can like sit up and talk to their relatives. But going from 100 to 50, in terms of uremic toxins, I don't know. I don't know if there's as much bang for your buck there. So to the group, do you feel sufficiently equipped now to take that call from your colleague you've got a BUN of 40 and no urgent indication and they want to start dialysis? Do you feel comfortable saying it's going to be better to wait a little bit?
Can I speak for the University Hospital?
Yeah.
You know, we really need to work on the culture at the University Hospital. People think that they can order CRT and we're just going to come up and do it. And I do think all of us are trying. You know, I certainly know that I have changed my practice in the past few years and am really encouraging people to wait until we have a clear indication. But while we've been trying to do that, our colleagues in pulmonary critical care and the STICU don't like that. So that's one thing. So I think we have to have a unified message as a group that it's harmful, right? Like it's not, it's not, neutral, it's harmful. The other part I would say is I have tried to do prolonged intermittent renal replacement therapy several times, and the pushback is actually from nursing. So I think it would be really helpful to maybe have a larger discussion with the critical care docs and the nursing staff about why prolonged intermittent renal replacement therapy is both helpful potentially to the patient, but also from a resource utilization standpoint, because we can use machines on more than one person. So that's a large culture thing that's going to take a while, I think, to affect.
If I may give my 5 cents on this, it's Godela. Often another culture change that's needed is fluid management, because often we are forced to start dialysis not because of BUN or potassium, but because of incredible fluid overload. These intensivists are continuing to give fluid in anuric patients, and we reach a point of 20 to 40 to 50 to 60 pounds of fluid overload, and we just are forced to start dialysis because of that. And often it's the daily fluid that these patients are getting that are just forcing us to continue with CUVH instead of intermittent, because they are getting 4 liters a day. We cannot remove that much fluid with intermittent dialysis 3 times a week.
I want to say one other thing. We have also lost fluid control to our colleagues in the ICU by giving them a spectrum of fluid removal. And I think that's kind of a slippery slope. And I think that we need to try to regain some of that control over fluid management. Yeah. But I love the talk, Sarah. This was great for the fellows, and for me as a reminder, because I do think it really gives us the information we need to continue to push back on starting people early.
I agree. It was an excellent talk.
Very good talk. I agree. Stu, I think you want to say something. I think there's a
no, not really.
Okay.
It's just the issue that we don't have those issues at Denver Health because we're so much smaller.
Sure.
And the ICU people are actually terrifically collaborative.
Yeah.
And so some of them attended both places, and that's the thing that strikes them, that how the size and the collaboration. So it's tough when you have a place the size of University Hospital and so many people coming at you at every one time to really get control of that situation.
Yeah, so many cooks doing
Are there
different things.
opportunities to do education Sarah, I was really pleased to hear that you gave a lecture to the ICU. And so often this conversation is in the heat of the moment when there's emotion and politics, and suddenly what's best for the patient and a thoughtful discussion is totally lost. And the idea that we might give talks like this in a sort of different environment and actually educate people why we have this perspective and why we want to delay intervention may be like a better way to help change this culture, because I just feel at a loss sometimes, and ultimately I just acquiesce, which, you know, is not a good feeling.
Yeah, I think I'm going to try to get on the CT surgery schedule, since I think some of you know I'm collaborating with the CT surgeons, and you know they care about their outcomes, and so I think that, yeah, I think if these studies, it surprised me because I didn't recall when they came out the significant harms, and maybe they did come out and I missed it. I kind of, the message was that everything was the same so that you could do what you want. I think that could be one message taken, but the fact that there's truly harms, especially you know, people might recover otherwise. And so I would think that a lot of people would care, because dialysis is such a quality control endpoint that if you do surgery and then your patient went on dialysis, like that's a you know, black check mark against you. So I would think they would kind of be happy to sort of move away from early dialysis.
I mean, Sarah, I think a talk like yours, to Scott's point, should be given maybe in some type of grand round in the Department of Surgery, correct? I mean, that, I think that.
Ooh, that would be really good.
Yeah.
Dr.
Yeah.
Johnson, I actually just gave this talk to
Okay, thanks, Annette. I did not know that. Yeah.
care group. So that's the surgical critical care group.
Okay.
I just gave it in September, and the topic was timing of renal replacement therapy.
How was it? Can we ask Annette, how was it received?
Well, it was on Zoom.
Okay.
So I didn't get any questions, but I did talk to a couple of their fellows later, and they thought it was very helpful.
Good.
I didn't talk to any intensivists as such off the bat.
I would say clinically too, though, like recently I've noticed that people consulting us for AKI, for CRT, they'll have already tried the Lasix challenge.
Yeah.
So they're starting to do that more.
I did push the furosemide stress test quite a bit.
Yeah.
So.
Can I ask one other question? And this is a training question. So some of the surgical ICU fellows will rotate through renal. And that was one of probably the most effective interventions I've had, which is that one of the surgical ICU fellows came through. And then when he was in the ICU, we had a good relationship and he understood our thinking. The MICU fellows never come through renal. And it seems sort of intermittent whether the surgical ICU's docs come through renal. And I was just wondering, does anyone know?
So Sarah, this rotation that's for the anesthesia critical care group, that was actually started like 4 years ago. And the feedback we got was so good that now they've almost made it mandatory for their fellows. So every anesthesia critical care, so it's the surgical critical care fellows, they all do it. And I actually coordinate that with their fellowship director. That's Jason Brainard. So, but I don't think that the medicine people, like, our interaction with the medicine fellows is much more limited than what it is with actually the surgical fellows.
Yeah, that's true. But most of those MICU fellows are going to go on to be the critical care doc in a facility where there's no surgical ICU intensivist, and they're the intensive.
Tristan Huey is, I think, their fellowship program director. If you want to reach out to him, that could be an option. But he doesn't work at the U. He only works at St. Joe's.
Thanks, Annette. Thanks, Sarah. Sarah, thank you so much for a great presentation. Great, very, very educational. So I appreciate
Yeah.
your input.
And
Thank
yeah,
you.
thanks everyone for the discussion. I appreciate it.
Yeah.
That was awesome. Thanks, Sarah.